All right, let's jump in. Welcome, everybody, to today's panel of value-based care and healthcare consolidation. I'm excited to hear from our invited expert panel to help us unpack these dynamic concepts and accelerate our journey towards true value from value-based care. First, I want to introduce you all to HBHI and our webinar series. I'm Dan Polsky, Director of the Hopkins Business of Health Initiative, as we call it, HBHI. It's a Hopkins-wide initiative bringing together scholars from across the university who are working together for an accessible and trustworthy healthcare system for the nation that delivers value and affordability to society through a focus on the role of business and incentives. As part of this effort, we host a monthly conversation on the business of health where we bring experts together to discuss emerging issues. Today, I'm serving not just as host, but as a co-moderator with my dear colleague, Amit Jain. Amit is a world-class spine surgeon and the Vice President of Care Transformation for the Johns Hopkins Health System. He is a 2026 United States Presidential Leadership Scholar and a member of the HBHI leadership team. I also have the privilege of introducing our extraordinary expert panel. We'll start with Liz Fowler. Liz is one of the most influential voices in value-based care and federal health policy. Most recently, she served as Deputy Administrator and Director of the Innovation Center at CMS, where she led the development and implementation of payment and delivery models shaping value-based care across the nation. Her career spans leadership roles across government, philanthropy, and industry, including Commonwealth Fund and Johnson & Johnson, and she played a central role in both the design and implementation of the Affordable Care Act. With more than 2 decades at the center of U.S. healthcare reform, Liz will bring a unique, comprehensive perspective on how policy, payment, and innovation come together to drive system change. I should also mention she's a distinguished a member of our faculty here at the Bloomberg School of Public Health at the moment. And we'll next move to Marty Gaynor. Marty Gaynor is one of the leading economists studying competition and consolidation in healthcare markets. He's the Lester A. Hamburg University Professor of Economics and Public Policy Emeritus at Carnegie Mellon, has held senior roles in federal antitrust policy, including Director of the Bureau of Economics at the FTC, and most recently a special advisor for the DOJ Antitrust Division. His research has fundamentally shaped how we understand the effect of consolidation on prices, quality, and market performance, and his work has informed policymakers both in the U.S. and internationally. So he will bring his rigorous evidence-based perspective to one of the most important debated issues in healthcare today. Our third panelist, Andy Ryan, is a professor of health services, policy, and practice, and he's founding director of the Center for Advancing the Study of Health Policy through Research at Brown University. Dr. Ryan's research focuses on the forces that shape the value and affordability of healthcare in the United States, and he is one of the most influential voices on this topic that we're discussing today. So I'm delighted to have you all on this distinguished panel. And to kick us off, I'm going to turn it over to Amit.
Thanks, Dan. And we're really delighted to have this expert group talk on some really interesting topics that I think all of us can really learn from. So first question for Liz. Liz, the word value-based care is thrown around a lot, and you probably hear it associated with every concept in healthcare, whether it truly derives value or not. In your view, what is value-based care and what are the key elements? What do you think makes something value-based care?
Yeah, thanks for that question. And thanks, Dan and Amit and HBHI for having me here. It's great to be part of this illustrious panel, and I'm really excited for this conversation. So I would describe value-based care it isn't a single model. It is a spectrum of strategies and approaches that are designed to move the fee-for-service payment system that rewards volume, more billing, more services, more charges, and toward a system that rewards better outcomes or value. So we describe it as paying for better care rather than more care. And I'd point to 3 common elements that I think are key in defining value-based care. Can describe it a lot of different ways, but I tried to boil it down in anticipation of your question. The first is care delivery redesign. So care delivery is more team-based, patient-centered, and grounded in primary care under value-based care. It's where prevention, care coordination, better chronic disease management, is all part of how we deliver care. It's identifying patients at greatest risk and intervening early. Those are all hallmarks of value-based care. And the care is integrated across care settings, primary care, specialty care, and behavioral health. The second is accountability. So we're replacing a volume-based fee-for-service payment and with a more sort of population-based payment where there's greater accountability. And more specifically, providers take responsibility or accountability for quality and total cost of care. And then maybe the third hallmark is that to be successful in value-based care, we need data and measurement, more timely data to manage populations, identify highest risk populations, develop the right tools and interventions. Then, and all of that requires data analytics, measurement of quality outcomes, and frankly, better patient experience. So, in a nutshell, if I had to explain it, that's how I would explain it.
Yeah, when you describe it like that, it seems like that's something all of us should aspire for, right? I mean, essentially what you're saying is do a better job for our patients, create healthier communities, and really do that in a way that reduces burnout. So that's wonderful.
Exactly.
Marty, you're an economist, and the word consolidation is something I learned, first year of undergrad years ago. What is consolidation in healthcare? What does consolidation have to do with healthcare? Why are we talking about this? And what is that intersection with value?
Right. So first off, a couple of quick things. Um, there's a very widely held belief, I actually would call it a faith, among many people in healthcare, both practitioners and policy people, that we need more integration. Okay. And what a lot of people don't see or perhaps miss is that something fundamental, consolidation does not equal integration. All right. So we have had a huge amount of consolidation in healthcare over the past few decades. This goes back, I'll say 1980s. It started a bit earlier than that, but 1980s. And a lot of it initially was like merging with like, hospitals merging with hospitals, doctor practice, insurers with insurers, et cetera, to the point where really the vast majority of urban areas in the US are dominated by a single large health system. So we've had a huge amount of consolidation. The other kind that's happened a bit more recently have been mergers or acquisitions where not between exactly the same things, not hospital to hospital, but a huge number of hospitals. Hopkins Health System does this, acquiring physician practices. Very few physician practices are independent practices anymore. And a bit more recently, some very large health insurers acquiring pretty much everything under the sun in the healthcare sector, with the exception of hospitals. So huge amount of consolidation. Now, so what? Right? That's not necessarily good or bad. A lot of people have thought for a long time that this consolidation would lead to integration and would lead to improved care for patients, getting us to, kind of place Liz was just talking about. But the sad fact is that has not happened. We have not seen an improvement in the quality of care. We have not seen costs dropping. We've not seen better continuity of care, any of the kinds of things that you'd want to see in terms of an improving health system. What we have seen are much higher prices, much higher costs, and in some cases actually compromised quality. So consolidation has characterized the healthcare sector now for quite a few decades, and unfortunately to its detriment.
No, thank you. Um, Andy, question for you. So what do you think is the difference between horizontal and vertical integration? Could you explain that to the listeners? And then also how do value-based care concepts intersect with consolidation? And why are we talking about those two concepts in the same panel here?
Yeah, sure. Thank you. So horizontal integration is, as Marty said, kind of like the acquisition of a combination of like and like. So a hospital system acquiring another hospital system would be horizontal consolidation, whereas a vertical consolidation would be, say, like a hospital acquiring a physician practice or a plan acquiring a physician practice. So it's like a dissimilar type of joining of entities. And so I think that actually vertical integration and in particular and value-based payment are two important forces in US healthcare that have kind of reinforced each other to make healthcare worse in the United States. And so, if we start with the plan to provider integration that Marty mentioned, I think that it's quite clear that a key rationale for these arrangements was value-based payment through the Medicare Advantage program, whereby, I think the Optum United relationship is the clearest example there. When the main motivation of this kind of integration is to capture patients, convert them to be United members, and then to upcode risk, which both of which I think have negative consequences for the US healthcare system. Relatedly, on the provider side, Marty described the hospital and physician vertical integration. And what's fascinating to me is the proponents of those arrangements. How did they justify those? They said, well, we need to coordinate care. We need to better manage care. We need to share information. We need to be able to take financial risk. We need to be able to do value-based care. That was very much the rationale for those vertical arrangements. And I think that logic was successful in overcoming some of the skepticism of regulators and policymakers about the anti-competitive effects of vertical integration. And so through that mechanism, I think VBP kind of gave the rhetorical cover for lots of vertical integration. And just to reflect briefly on why this matters, I completely agree with Marty's statement about the negative impacts of vertical integration on spending in particular in the United States. And, my view is also that value-based payment itself has not improved value. It hasn't reduced spending, hasn't been the cost curve. And in addition to increasing vertical integration, I believe it's also added to administrative burden and distracted policymakers from the true solutions that would actually address affordability in the United States. So I think that, in important ways that might not be real obvious, value-based payment and vertical integration are these tightly linked forces that I think really need to be kind of unwound. And, I think policymakers really need a new paradigm for thinking about how we should address some of our systematic problems.
So, so this was a perfect, way to kind of lay the groundwork of the key concepts, but also we've thrown in all the major topics we're going to dig into now. And I can see the panelists, waiting to respond. And so I'd like to, just for a little organization, maybe zero in on a lot of the issues that came up around consolidation and its link to value-based care. And I guess Marty will start with you, but then open it up. And kind of thinking forward, can you speak maybe a couple of examples of organizational structures that might where value-based care might thrive, or how best to unpack it, or maybe just tackle or respond to some of the things that in this topic that came up already.
Sure. I'm not going to give examples of specific organizations because I operate where the rubber meets the sky. But I'm sure Liz or Andy or you folks could give examples. But I will say one thing. In general, consolidation is neither necessary nor is it sufficient. You could, I think, and I'll let Liz and Andy weigh on this. I think you could deliver value-based care through sets of independent organizations that have arm's length relationships and do that quite successfully. My understanding is there are some organizations that do that, and you might also be able to do it through an integrated organization. But remember, again, consolidation does not necessarily mean integration. Consolidation is only the first step, and you can achieve a lot of coordination that gets you to sort of integrated like outcomes with still being independent. I think the evidence does not show that consolidated healthcare organizations do better than independent. So I think that's something to be aware of. But then coming back to one thing Andy mentioned at the end, we do have to be thoughtful about how we design things like value-based payment in a way so that it encourages what we're looking for, but it doesn't sort of inadvertently drive things in a particular direction. And so I think that's something to be very thoughtful about. And in principle, value-based payment, how could you possibly object to that, right? But you do it, but there are lots of things that Medicare has done and still does, as a matter of fact, that inadvertently have encouraged a consolidation as a response to the way that payment systems are structured, not because consolidation is better in any way, shape, or form. It's because these entities opportunistically take advantage of that. So I think that takes some thought, but I don't know that you necessarily need to have consolidation to truly achieve value-based care.
Follow up from Andy or Liz. Liz, you want to go?
Yeah, I do want to jump in. So I do think, and I think this is such an interesting conversation because I do think the issues are entwined. So value-based care changes the economic incentives of the system, and organizations respond by restructuring, developing partnerships, hopefully in order to be able to succeed. And for that reason, the issues are connected. But consolidation isn't required for value-based care. Success in value-based care requires organizational capability and coordination, but it doesn't necessarily require that consolidation is needed for that success. Greater scale is helpful, but not necessary. Organizations need capabilities to succeed, and these capabilities can be expensive to build. Analytics, we talked about care management, risk management. But I think the policy challenge is how do we enable the capabilities required for value-based care without allowing market power to drive prices up? How do we think about designing payment models and market rules so that consolidation isn't necessary, and when it does happen, it supports value rather than undermines it? And we thought about some of these questions at the CMS Innovation Center. Could CMS play a role in supplying the data and the analytics that help primary care practices and be successful? ACOs, for example, identify the highest need patients, high value specialists, and not need to go out and sort of buy or build those capabilities. So I think that is something that's top of our mind. And I think there's also organizational models that can support value-based care without excessive consolidation. Networks of physicians in an ACO, clinically integrated networks. There's the convener model, organizations like Aledade that work with organizations without needing sort of an acquisition strategy. And I think those are organizations that provide the infrastructure and allow small practices to participate in risk models without sort of needing to have that sort of overall financial acquisition or consolidation angle. There could be virtual integration through contracts, so alignment across organizations without a full merger. I think the goal of value-based care is really the integration of the care, not the consolidation of ownership. I guess, and this is probably a whole separate conversation with Andrew, like I understand that a lot of people are skeptical that value-based care hasn't worked, that it isn't delivering what it said it would. I guess it's really hard to tease apart, but I do think there has been an impact of a lot of things that have been tested and tried over the last, since the ACA passed in 2010, and really, I think, catalyzed more activity in this value-based care space. And I point to some of the research and studies done, including by Melinda Bunton, who's part of our faculty, looking at why is it that when the Congressional Budget Office projected what spending was going to be in our healthcare system 10 years out as part of the ACA, if you look at what actually happened, health spending is about, 17% lower, and specifically in Medicare, than it was when it was projected 10 years earlier. So something is happening in the system. I think it's really hard to tease apart exactly what happened and why that's the case. I think it's, you could say, well, it's COVID, it's this, it's that, but I think there is an impact there. We tried to figure out what those forces were. We looked at the spillover impact of value-based care and different angles. Maybe I should stop there, but I do think there is a positive impact, and I have seen it in in my work and time at the Innovation Center, really delivering that patient-centered care that we would want to see in our health system.
Marty,
Yeah, thanks, Liz. That's super, super helpful. I will say that you touched on a couple of things that do give me some pause and some concern. So, shifting risk to physician practices, I think the upside is, look, you don't get incentives that have any power without people bearing risk. That's just the nature of these things. On the other hand, the more risk you shift to physician practices, the harder it is for them to diversify that risk on their own without doing something, either buying potentially effectively insurance policy, which could be very expensive, or increasing scale. Right. And so I think that has to be done in a very thoughtful way. Another aspect of this is the following. We're now shifting risk from organizations that are built and designed to bear risk, insurance companies, to those that are not, healthcare providers. And that strikes me as potentially inefficient, and I'm not sure that's necessarily the best way to go. Again, I think some of that is in order and fine, but I think we need to be thoughtful about that. And as a data analytics, some of the same issues apply. If you can purchase or obtain that, like you said, I know that CMS was thinking about, are there things that we could do to act to provide those things so that smaller practices are not placed at this disadvantage they simply can't overcome without becoming part of a much larger organization or what have you. But I think those are both factors to be considered very carefully. And I'll say that I'll shut up in just a minute. The data analytics part actually is an issue that's much broader than value-based care. It's driving a lot of what's happening, and as AI comes on the scene, it'll become even more important. So there is this. We're seeing again a drive towards very, very large, supersized organizations in healthcare. I don't think are delivering for us, and so I'm not saying value-based care is no good. Let's never do it. Don't get me wrong. But this has to be done thoughtfully, and it may require actually kind of threading the needle.
I want to give Andy a chance to jump in.
Yeah, great. No, thanks. I'm struck when we think about like value-based payment that so many of the benefits remain theoretical, and the individual program evaluations have been so underwhelming that I think a lot of proponents have turned to the kind of spillover theory because, there's evidence from the CBO study that these CMMI portfolio, has lost several $billion. And so the spillover theory that I think Liz alluded to basically holds that spending growth was kind of lower than expected after the ACA. So that's because of value-based payment. But I think a close look at the evidence there suggests that's really not the case, that several things happened. Number one, the spending growth in the United States began to decline prior to any of the value-based payment initiatives. That's number one. Number two, this is shown in a paper by Newhouse that basically we had the same spending reductions across OECD countries that we saw in the United States. And then three, it was tied to a kind of like measure of technology adoption. And you kind of like put that together, and the evidence that something unique happened in the United States that was related to value-based payment is just is quite poor. I think like this question that Marty raised and that Liz raised about the role of like middlemen is super interesting because like when you come, the original concept of ACOs and stuff like that is like providers would kind of come together and they would manage patients and stuff like that. And it kind of turned out that providers just, as Marty alluded to, just like aren't very good at this. They're not really good at being insurers. Many of them they don't want to be insurers. They want to be providers. But so much of the risk contracting idea of VBP is trying to act, making everyone like little baby insurers. And I think that really has increased administrative burden. It's brought these people like Aledade onto the scene who basically say like, look, you just do what you're going to do. We're going to help build portfolios of ACOs that game benchmarks, maybe help you with some coding on the margin, and then that's the strategy that we'll take to win in these ACO models. And this is my critique of VBP and risk models in general, is that in many ways it encourages behavior that's just inconsistent with what we think is of as efficient clinical practice. It's like it's like middlemen function that's really like a lot of it is a selection and risk game. And it gets to the broader issue, which I hope we can discuss, is like why have we focused so myopically on provider risk taking as the strategy for spending reduction? It's like a fascinating question. Like, why do we go down this road? Why aren't we focusing more on prices? Why aren't we focusing more on coverage decisions? Why did it all come down to provider incentives and risk and VBP?
So I think that's a good segue. Maybe I want to just say I was remiss to push the Q&A function for all of our attendees. Please take advantage of the Q&A function. We'll be sure to leave some time at the end for questions. But I'm going to turn it back over to Amit. I think our planned questions are all being answered simultaneously. So, but
could I just say one thing? I think it's worth pointing out here that value-based care is not about insurance risk, it's about performance risk. And I think that's very different. I don't think that an ACO is a mini small insurance company. I think that's maybe the wrong way to look at it. And even in the Medicare Shared Savings Program, those organizations are not bearing, they're not, some of the pathways aren't taking downside risk. So I think anyways, I just wanted to point that out that might be a misconception that they're bearing insurance risk.
But they are bearing risk. I mean, that's at the heart of it.
Yeah, for performance, and
right, but
we want them to do better than what we're predicting.
Right.
And I think the MSSP program every year, CMS says that they are generating shared savings for both Medicare and for the participants. So.
Yeah, I mean, Liz, correct me if I'm wrong. But my sense is that the research evidence, and these things have been going on for a while, in one form or another, is not super encouraging. There are some things that to point to where it seems like, something good happened, but a lot of it, I'd say the bulk of the evidence either finds nothing, and maybe it hasn't been done right yet. Maybe not enough time.
Yeah.
No downside risk. I don't expect to see much of anything happen, and we didn't. That's not a big surprise, I suppose. But again, I think in principle, the broad idea of paying for value, separating it from whatever is actually being done in practice right now. Of course, that's a perfectly reasonable thing to do. But again, I think like all these things, we know the devil's in the details, and so doing it right is no small matter. I do want to just jump in. I think this is a little pedantic, but I'm an academic, but not too much. I think with regard to fee for service, right, and we often say, it rewards volume. It really depends on where the fees are set, right? So back in the day when Medicaid paid fee for service, there was the volume problem was that not doctors didn't want to see Medicaid patients, or there wasn't enough volume. So it really depends on where the fees are set for fee for service. And in principle, if you get all the fees right, you could get exactly what you wanted. The difficulty, of course, is there are thousands of fees, and getting those things right or sort of close to right is no small matter. On the other hand, getting a value-based payment system right is no small matter as well. So I think we need to think a little bit harder about this. I wouldn't say let's not abandon this. And if you think about it too, if you think about what we're dealing with in many markets that are dominated by either monopolies or pure monopolies, if we go, Medicare pays administered prices, but even if we go to price caps on the private side or administered prices on the private side, which are being discussed, you need to think about what you're paying for and value should be part of that as well. So, I know this is a beyond the scope of what we're talking about right now, but the idea of value-based payment is a very important one. I think something we need to be grappling with.
I think these are great points. And I guess the concept of evidence around different value-based care models has been brought up a few times now. And I wanted to unpack that a little bit. So, Liz, could you tell us a little bit about different ways that value-based care has been implemented, that CMMI has looked at, things like all the way from the Maryland model, which is capitated, to much more risk-based approaches, to kind of a shared savings approach, and what the evidence supports, or just to give us a brief overview of what the evidence is for each of those. Um, Recognizing that it's a lot, you could probably spend a week giving us a seminar on this. And then finally, where do you think the future needs to be in that? Or are we still kind of in the experimentation phase where we're trying to kind of wet our feet to learn about what works, what doesn't work, to actually truly improve population health? Because there's pay for performance, but then there's actual population health improvement. And what actually drives population health improvement?
Well, there's a lot in there, so I'll try to jump in, and you can tell me if I missed something. But I guess I would describe the categories of models that CMMI has tested. First of all, to look at the primary care models. There's been a lot of trying to invest more in primary care, bring up the primary care infrastructure, find ways of bringing them into maybe an alternative payment system like partial capitation. I think the ACOs is maybe the next level of sort of accountable care models. Could we provide some of the incentive payments up front? Could we test higher levels of global risk as opposed to sort of just downside only? So there's sort of like a whole category of primary care and accountable care models. There's also a category that I would describe as more in the specialty space, the oncology care model that I think we did see increased use of biosimilars when you pay sort of, I wouldn't describe them as an well, I guess maybe it's an episode model, but with incentives. Some of the kidney models that have actually seen the impact of helping patients avoid crashing into ESRD, doing more dialysis at home, more on the nutrition, trying to keep them from CKD, chronic kidney disease, stage 4 from dropping to stage 5. And then some of the episode models in the bundle payments, hip and knee payments, and now the team model that's a mandatory model. There have been state-based models. Maryland is one. I think we more inherited the Maryland model, but also the Vermont all-payer ACO, the Pennsylvania rural hospital model, but also trying to look at whether we could contract and work with states, maybe as a payer and as a participant, and Medicaid programs. And then there's this sort of segment of population health models as well, the accountable health communities that tested whether you can screen and refer for social health needs. And I'll tell you, this is one of the problems with the CMMI. It turns out that screening and referring for social needs, addressing food insecurity, housing, transportation, actually does drive down health spending and avoid hospital use and emergency department use. But unfortunately, that model, which ran from 2017 to 2023, the final report just came out 2 weeks ago in 2026, so 3 years later, and said that we saved $200 million and avoided hospitalization. So I think that's part of the challenge is, well, there's many challenges as CMMI. One of them is that most of the models have been voluntary, so they have suffered from risk selection. So if organizations are doing well, they stay in the model or they join the model. If they're not, they, exit the model. And then one is just this, how you determine what is success. And the way that the statute is written, it calls on the CMS actuary, or at least as it's been interpreted, to determine whether there's been savings on a net basis that is 95% certain to last into the future. And so I think the bar is very high for these models, and I'll give you one example. I mentioned the Medicare Shared Savings Program and the savings every year that accrues to both the program and the providers. In parlance of the Innovation Center, those shared savings that go back to Medicare or back to the providers are considered to be counted against the net savings. So it's almost like you dig a hole and you can never quite get out of it. So um, I think it's a sort of tortured history of trying to describe how I do think some of these have been successful, even though either the evaluation comes out too late or they didn't quite meet the hurdle of the net savings. I don't know if I've answered all of your
No, and then
questions.
I fully recognize there's a lot to unpack here, and you could, people have written entire textbooks on each of these things you mentioned, but I just wanted to kind of get everyone's quick reaction. So, Andy, I see your hand up first. So, Andy, and then Marty.
Yeah, great. So actually this notion that the CMS is generating shared savings by virtue of ACOs beating benchmarks. I mean, this has been discussed repeatedly, but I just really want to emphasize that this is not real savings. All it means is that ACOs are spending less than the benchmarks, and there's the whole idea these benchmarks are not true counterfactuals for what would have happened in the absence of the program. So we wrote a paper called "All I Do Is Win," and it's about how ACOs have, the savings that CMS has claimed they've generated can largely be attributed to different forms of selection and upcoding. And this has really accelerated in recent years. I think it's been aided by like the middlemen like Allidaid. And it's also in the regional benchmarks really opened the door to a lot of selection that then CMS counts as savings. On this point, like that it shouldn't count as savings if the net savings that it matters. Of course, it matters how much like CMS. It matters how much CMS pays back to providers. Like that's the whole point is to save money. So if they're paying, paying too much back to the participants, it's pointless. They're not saving money. I mean, I think another thing I think is so important is this idea of primary care. And, in so many ways, VBP has kind of elevated primary care. Primary care is at the heart of it. We need primary care. We need primary care physicians to like ration care and managed care and stuff like that. And, I think there's so much rhetoric around that. But at the same time, I think there's, as a kind of Marty has alluded to, like these models are asking primary care physicians to do all kinds of stuff that are quasi insurance functions. And I think it's like inconsistent with how primary care practices want to spend their time. I think it's one of the reasons why panel sizes have fallen over time with in primary care, that physicians are just seeing fewer patients because they don't have the bandwidth to do so. They're so busy with administrative work. I think some of that is VBP. Some of these other models are so interesting, like the follow-up to the oncology care model has been like completely colonized by like private equity aligned practices. It just kind of speaks to the kinds of like middlemen and kind of like corporate entities that have gotten into the VBP game. Because again, there's this vision that like it's providers who are kind of coming together to do the right thing in managed care. That's like the vision of VBP that like Liz laid out. But the reality is just very different. I mean, the kind of entities, the third party conveners and middlemen who are basically getting together to kind of help providers basically game CMS payment. So, I mean, I think this is the whole, as Marty's kind of alluded to, the rhetoric of VBP is so hard to dispute. Like, why would you just pay volume when you could pay for value? But the reality is just very different. And I just want to finish by upping this point about fee for service, and that I think like, the fact is that these VBP exists like below a layer of fee for service. And we kind of went ahead towards these risk models without fixing the underlying guts of fee for service. I think that's proven to be a huge mistake. All these low value services keep coming on the fee schedule. I think the skin substitutes is one example. All kinds of, and then we're saying like, okay, providers, you manage all this stuff. You figure out how to, provide high value care when we're letting all this low value care on the fee schedule that, you have an incentive to do more of. So to me, like the first order issue here has always been to fix the fee schedule. But under VBP, a lot of like the leading thinkers have just thought of fee for service as so inherently flawed and pointless. It's like not worth saving. We got to just go straight to risk. I think that's proven to be a huge mistake. And our time and just things like, things like the inpatient only list is just like basic kind of changes to how we do like fee for service and Medicare that's likely saved billions of dollars. There's stuff like this in the fee schedule. And instead, we've kind of pursued these complex risk adjustments on the basis of the theoretical range of their benefits. And so I think this is like the kind of
let's give Marty,
misallocation. Yeah.
if it's okay to give Marty a chance to chime in before we move to the last question.
Oh, no, Andy,
Marty,
go ahead and finish your thought. I don't
Marty, the one question I was going to ask you is just to reflect on Andy's point. How do you see this phenomena in other industries? Like, do you see middlemen inflection in other industries that have been essentially having to go through some of these transformations?
Well, yeah, I guess it depends on the industry. It depends on what's going on. So, I mean, one thing with healthcare, of course, is the very, very large role played by the public sector. Medicare and Medicaid, of course, add up in terms of spending to approximately half of all spending. And it's hard to find another industry in the United States that looks like that. Education, I guess, certainly comes to mind, but is organized in a very, very different way. So, so you do again, middlemen can be very efficient, right? Middlemen can specialize in things and make sense for them to do that other firms in various parts of the sector can't do as well. That can work. That can work just fine. But I think we do have to be asking ourselves, when this is driven by choices the public sector is making, public policy, is it getting us where we want to go? So that's a question. And at some level, I do wonder a bit to what extent can policies like this that are focused on docs and primary care docs in particular sort of really drive a whole lot of change when the sector now is dominated, like I said earlier, by gigantic health systems or gigantic insurance conglomerates that are insurance and all kinds of other flavors of healthcare, and most of the doctor practices are owned by these gigantic entities anyway. So again, that doesn't mean we shouldn't do anything. I'm not taking a nihilistic approach, but I think we need to be thinking really hard about what we're doing at that end of the healthcare sector. And some of this stuff, has happened, and there's no going back. It might be the best thing to do would be to break up United Healthcare into constituent components, to break up, for example, University of Pittsburgh Medical Center, which is practically in my backyard. If you looked out the window here, you could see
literally in your backyard.
yeah, actually, I can see it from my backyard. So what was the U.S. Steel Tower in Pittsburgh, because of course that was the most important industry in this region for decades, is now the UPMC Tower, because that is the most important industry in this region and probably in the entire state. Now it's not easy to do those kind of things. I don't know that we're going there, but I think we need to be paying a lot of attention to what's happening there. So this is a very hard problem, and just because you can't solve everything at once doesn't mean you shouldn't try to address something. And if you can improve quality care for patients a non-trivial amount, I'll take it. If you can drive down costs, it doesn't have to be 10%, doesn't have to be 5%. It could be half of 1%. That's still a lot of money. I'll take it. But what makes this so challenging is we have this this large complex system. We haven't talked really about the private side of healthcare, which is half or a little more than half. And the incentives there, there's so much money on the table, right? We're talking about trillions of dollars in this sector that it can swamp even the best designed incentives for value-based care or anything else. So we need to be, when we design these things, we need to be taking account of all these things. And I know Liz and the folks she worked with at CMMI, very thoughtful, very smart people, know all these things and thought really, really hard about them. I don't know what's going on there right now or what may go on in the future. But it's a tough problem, and I think it might behoove us to take a step back
So
and think about some of these things again.
can I segue into like a final move towards wrap up here because we're getting some great questions in the Q&A, and I want to turn to that. But maybe just kind of want to give all the speakers who have, I think, mentioned potential solutions, ways forward, to take 1 minute each. We'll start with Andy, who mentioned things like fee schedule and prices. What should we prioritize here, given all the issues on the table? If you had to set the priorities for the current administration to address some of the issues that came up today, double down on value-based care, moved in other areas, what would you put at the top of the list? We'll start with Andy, and then we'll go to Marty, and we'll give Liz the kind of the chance to close this part before we move to questions.
Yeah, great. Thank you, Dan. So I'd say three things. Number one is fixing the fee schedule. That Medicare fee schedule is so influential. It's carried forward in, commercial in particular, also Medicaid to some extent. And so there's lots of just distortions. The AMA controls the CPT system. There's way too many codes. The specialty societies control the RUC and the valuation of services. That really needs to change. That would have huge impact on spending if we had a more rational fee schedule of which would have like many fewer codes bundling at the level of the fee schedule as is done in other nations. So that's number one. Number two is around coverage policy. I think this is most clearly seen related to like drugs. It's absolutely insane that CMS doesn't have clear authority to not cover a drug on the basis of its cost. That's just crazy. And that should be a basic consideration when something enters the fee schedule and CMS, not just drugs, but also new devices and procedures. There's very little scrutiny. It's very laissez-faire. And we know over the long term as technology changes that drive spending growth and how they're priced. And a huge part of that is CMS. The problem there is how CMS has approached coverage. And last thing is prices. We have inflated prices in Medicare through things like, facility fees that have happened because of vertical integration. But of course, it's much worse on the commercial side. And, our market forces have not worked as we would have hoped because of all this consolidation to keep prices reasonable. So I think policymakers need to step in to do more direct price regulation. So that's my agenda for reducing spending growth in the future.
Thank you, Andy. Marty, you're next.
Well, I'd say in the immediate and short term, get the folks at CMS, CMMI, where Liz was, and various relevant parts of CMS, and the folks in the antitrust division of DOJ, and the folks in the FTC, and Domestic Policy Council, the National Economic Council, to sit down and talk to each other on a regular basis and formulate plans going forward. There are a lot of really smart people in all these places. Many, not all, unfortunately, but many of the career public servants in these entities are still there. They're very knowledgeable, very thoughtful, very smart people, and to talk to each other. And we certainly did that when Liz was CMMI and I was at the antitrust division. And people may be doing that now. I'm not saying they're not. But I think that's very important because then it can put their heads together and really work on designing things that work well. Pie in the sky, which is not short term and may never happen, would be let's head straight to go and have national health insurance for everybody in the U.S. You could put a private supplement on top of that. If you want, hospitals get paid a fee schedule, get administered prices, and doctors are on salaries, and we would just take it from there. I think that would be not just much simpler. I think we would actually be spending less money and have no worse quality of care, maybe even better quality of care.
Okay, Liz, your turn.
Well, first, let me just second what Marty said. I do believe we need to get to a place where we have universal coverage. The fact that we don't have universal coverage, that healthcare is not considered a right in this country, we seem to be making two steps back. So two steps forward, one step back. Sometimes it feels like two steps back, and certainly, the new work requirements and 6-month eligibility redeterminations in Medicaid that go into effect next year, I think feels like two steps back, not just one step back. And so I think, if we're talking about improvements to the health system, second is I remain optimistic about value-based care despite everything that Andy said. And thank you, Andy. I appreciate your perspective. I still believe that there's a way to have better incentives and a better way of paying for providers. And I also think there's ways of trying to relieve some of the administrative burdens. We've had 50 years of fee-for-service in Medicare. And so I don't think that is the way to solve the problems. And I don't think that that's the way to make it less administratively burdensome. Working on the Affordable Care Act, we did look, and I was trying to read some of the questions as we're having this conversation, this whole notion of integrated systems like a Kaiser. I think that is what we were trying to strive for is there a way to align incentives where everyone is working towards the betterment of patient care, the betterment of an improved patient experience in our health system? Obviously, we're a very long way from that, and it feels like we're, again, moving in the wrong direction. But I do think that there is a way to incentivize value in the system where patient experience and patient care is at the center of what we try to do, where primary care is the sort of foundation of a better health system, where everybody has a quarterback or a primary care practitioner who's helping them navigate the system, and care is team-based and more coordinated. How you get there, I think, remains to be seen. I think we have a lot of experience in this realm now after, 15 years of ACA and testing different approaches. And I think you can't work at the Innovation Center unless you're a optimistic person and you believe there's a path forward. And I do believe there's a path forward. I do think we need to sort of look at what's happened in the consolidation in our market and think about what the solutions are. Thank goodness there's people like Marty who've done so much good thinking on this area. And ideally, we can find a path together towards a better healthcare system.
You want to ask some of our excellent questions here or kick us off?
Yeah, that was really powerful, Liz. Thank you. I was just reflecting on what you were saying. And I was looking at some of the questions here. I think one of the things we all focused a lot on is thoughtful approaches to payment reform. And I think a lot of Andy's answers and Marty's answers focused on that. And you focused a little bit on quality improvement. So how do we think that value-based care is the vehicle to actually improve population health? Because there is improving healthcare delivery, which is one thing, but then there is improving population health and making folks healthier. And maybe putting resources in primary care is the answer. Maybe it's not. I don't know. I'd love to hear your thoughts. And then the question is, how do you actually incentivize prevention? Because a lot of things we talked about so far are focusing on providers, but then there's this whole aspect of value-based care, which has to do with Medicare Advantage or other kinds of vehicles that essentially aim to think more about population health risk. So could you all comment on that?
Well, so I think sort of mixing up population health, and it's extended beyond that, housing and nutrition and stuff like that, with healthcare provision is a mistake. Look, population health is important. Don't get me wrong.
I'm glad I asked that question because
Yeah, I think that's a gigantic mistake. Here's something very simple and not that expensive we could do, and we don't do enough of, is we could fund more community health centers. Community health centers, locate them in disadvantaged areas, either in rural areas, and it doesn't have to be a gigantic thing. It can be a small clinic. You can have a visiting nurse. There's lots of things you can do. In disadvantaged urban areas, a big part of the problem is people can't get to care. Affordability is an issue, of course, but we know community health centers are effective and they're not very high cost. And that's got nothing to do with payment reform. I'm a little cynical about payment reform because anybody's been around a while, and you can see I don't have as much gray hair as I should, given some of the things my kids have done, has heard acronym after acronym after acronym of payment reform, and people act like, it's a new thing. It's the bright, shiny object. And after a few years, it doesn't do anything. It's forgotten and we move on to the new thing. So I think we have to be a little circumspect about this. Payment reform is not going to solve all the problems of the healthcare system. It doesn't mean it's not important, but again, I think we need to step back and think about this from a holistic perspective. And again, there's some very simple things that we could do right now that wouldn't cost a lot of money that would help a great deal.
I want to agree with Marty there. I think we've created this like very high degree of difficulty with like what we're expecting the payment system to do. It's going to pay for the right things. It's going to create incentives for quality. It's going to help facilitate equity. It's going to do, and my view of this is like we haven't gotten some of the basic building blocks of payment right, but then we're trying to do third order things with it. And so, the idea that we focus on a payment system that provides, that balances the actual payments with the value of the service and facilitates the right kind of access to care that we want, to me is very first order. And that should be a point of emphasis. I love the community health center idea. I'm totally on board with that. One of the things that's so important to think about is like in light of how much we spend on healthcare, that we simultaneously have these major access problems. It speaks to something that's just like really off in how we do things, and that we need a very fundamentally different approach to like resource allocation in healthcare. And the road we've been going down, frankly, is not going to get us there.
And consolidation is the culprit behind a lot of this, because consolidation has increased market power and made it more and more profitable for health systems to treat very profitable, high-paying patients with private health insurance, and then they want to see those people first, and they're much less interested in seeing people who have much less generous payment coming with them, let alone people without any health insurance at all.
But I just want to, like, one last point here. It really is all about the incentives in the system. And I think maybe Marty made this point early on. You get the system that you have designed, and the things that we're incentivizing is sort of what we have. And I think there's a better way to do things. I think we should not stop experimenting just because we think something hasn't worked. But this notion that you're going to point to the culprits in the system who are doing something wrong, and like it's the corporate interests, it's the hospitals, it's the plans, it's the specialists. It's like you can point to any drug companies, any aspect of the system, but it is really about the system that we've set up and the incentives in the system. And so I think what comes, maybe back to what are the incentives we put in the system, and did we get what we basically asked for? And I think we have. And so we need to take another look at this, but I think do it holistically. I liked that idea of like taking a step back and looking at it holistically. So I remain hopeful that we can have a better healthcare system, and but we're all in this together, and we need to solve these problems together and stop pointing fingers and think about a better way to deliver a better healthcare system for the people that need it.
I do think
I
that
mean,
that's indicative of a very like win-win orientation that's been the maybe part of the original sin of value-based payment, frankly, that we can all get on the same page, do the right thing, everyone's going to be better off, and we can kind of hold hands and make a health system better.
Andrew, you've been very negative the whole time, and I have not heard positive, like what is going to work?
I've told you the agenda. There's the three things. That's the agenda. And it's kind of like we've pursued all this other stuff. And it's led us to a place that hasn't improved the system. And I think that's like we need to recognize that's the case. Another 10 years of experimentation like isn't going to get to a fundamentally different recognition about like where we are.
So we are at 1 o'clock. So I'm gonna thank our amazing panelists for solving all of healthcare's issues in 1 hour. Really tremendous. I was hoping to end on an optimistic note. So our editor may make some changes to the final video, but you will be receiving our video, which we send out and put online to share. We had so many amazing questions in the Q&A. We'll share those as well. We didn't have a chance to get to all of them. So thank you to all of our audience, and thank you to our panelists. Thank you to Liana for organizing this, and thank you to Amit for organizing this session and coming up with the idea. And
Dan, the only thing I will just add to on an optimistic note is this type of vibrant debate can only happen in the United States of America. And that's what I love. I love the fact that we were able to have this type of vibrant discussion and open idea exchange. And really, I love that. And growing up in another country, I can tell you it to be true. So really very exciting. And thank you to our panelists.
thank you.
You. Thanks, everyone.